Hello, and welcome to the Power Tools webinar series. My name is Danae Schmidt. I am the Member Relations and Operations Manager here with USBC, and I'm so glad to have you join us for today's session. The Power Tools series is organized as part of the USBC's technical assistance and capacity building support for our network of state, territorial, tribal, local, and cultural breastfeeding coalitions, community-based organizations, and national nonprofit organizations. Access to these webinars is free and open to anyone wanting to strengthen their organization's capacity to advance policy, systems, and environmental solutions in the first food field, and we hope that these sessions bring ideas and inspiration. To streamline access, these webinars have been set up as a series so that once you're registered, you'll receive announcements for each Power Tool session with the topic and speaker details. We understand that it's not possible to attend every webinar live, and so all the webinars are recorded and archived so that you can watch them at your convenience. For slides and handouts for this session and to access recordings of past sessions, you can go to the Power Tools webpage at usbreastfeeding.org/power-tools. To find the Power Tools from our homepage, go to usbreastfeeding.org. You'll want to click on the Learning Collaborative tab, and then click on the Power Tools option. Will take you to the page. For today's session, all participants are in listen-only mode during the presentation portion. We hope that this session will be interactive, so please be sure to share your insights and questions as they come to you throughout the presentation by using the chat box. And here's how you do it. Go to the control panel on the right of your screen. If you don't see it, it may be minimized. Just click on that orange tab and it should pop back out. If you scroll down below the audio section, you'll see a tab for questions. And then when you click on it, it will open up a box for you to type in. For the best audio connection, we do recommend dialing in rather than using your mic and speakers, which is dependent on your Wi-Fi connection. So to switch your audio from computer to phone, go to your audio tab, select phone, and dial and using the information provided. If you do continue to have issues or you're having any other webinar related tech problems, please send an email to coalitions@usbreastfeeding.org and someone from the staff will do their best to help you. And that brings me to today's topic, the role of law and policy in assisting families to reach healthy people's maternal, infant, and child health breastfeeding goals in the United States. Rates of breastfeeding initiation and duration in the U.S. fall short of national health goals, including those in the Healthy People Initiative. Legal and policy solutions can play an important role in creating and sustaining the maternal child health systems and environments that help all families achieve their infant feeding goals. This panel discussion will share information from a new report recently released as part of the Healthy People Law and Health Policy Project, a collaboration between the Federal Health and Human Services Office of Disease Prevention and Health Promotion, Centers for Disease Control and Prevention, and the CDC Foundation and the Robert Wood Johnson Foundation that examines how communities can use law and policy interventions at the healthcare, workplace, school, and community levels to achieve healthy people's objectives related to breastfeeding. This session will highlight key findings from the report, including summarizing existing laws and policies that impact breastfeeding families and sharing specific initiatives from the national to community level that demonstrate emerging trends in breastfeeding support and policy. I'm thrilled to introduce today's presenters. First, Allison Stube. Dr. Stube completed her obstetrics and gynecology residency at Brigham and Women's Hospital and Massachusetts General Hospital in Boston. She completed fellowship training in maternal fetal medicine at Brigham and Women's, and she's earned a master's in epidemiology from the Harvard School of Public Health. She has published more than 150 peer-reviewed articles. She is currently a professor and board-certified maternal fetal medicine subspecialist at the University of North Carolina School of Medicine and distinguished professor of infant and young child feeding at the Gillings School of Global Public Health. In the clinical arena, she is medical director of lactation services at UNC Healthcare, and she works with an interdisciplinary team of faculty and staff to enable women to achieve their infant feeding goals. Her current research focuses on developing models for holistic and equitable care of families during the fourth trimester. She is a member of the steering committee for Moms Rising North Carolina, and she is actively engaged in professional organizations. She is president of the Academy of Breastfeeding Medicine and a former board member of the Society for Maternal Fetal Medicine. At the American College of Obstetricians and Gynecologists, she is a member of both the Breastfeeding Expert Work Group and the Maternal Mental Health Expert Work Group, and she chaired the task force on reinventing postpartum care. Welcome, Allison. Angela K. McGowan is the project director of the Law and Health Policy Project, a collaborative effort of the Centers for Disease Control and Prevention, the Office of Disease Prevention and Health Promotion within the Office of the Assistant Secretary of Health, U.S. Department of Health and Human Services, the CDC Foundation, and Robert Wood Johnson Foundation. The project aims to advance the use of law and policy to improve health. She leads the efforts of partners and subject matter experts within and outside the federal government to develop evidence-based reports highlighting the state of laws and policies related to specific topic areas within the Healthy People 2020 initiative. Previously, she was a senior project officer with the Robert Wood Johnson Foundation, working on many health issues, including furthering the use of policy, advocacy, and law to aid in creating a strong and comprehensive public health system. Angie served as a member of CDC's Epidemic Intelligence Service, working primarily with the Guide to Community Preventative Services on violence issues, and serving as a legal services officer with Georgia's Division of Public Health. She earned her JD from Vanderbilt Law School, her MPH from Rollins School of Public Health, Emory University, and her BA in International Relations from the College of William and Mary. She is currently a member of the William and Mary DC Alumni Board and the American Public Health Association Science Board. Welcome, Angie. Cheryl Lebetovich has been working with the United States Breastfeeding Committee since 2009 and has held many titles and responsibilities during her time with the organization. Currently, Cheryl helps lead USBC's advocacy campaigns and communications and assists with legislative strategy. She was lead author of the USBC's online guide, What You Need to Know About the Break Time for Nursing Mothers Law, is steward of the Workplace Support Constellation, and developed an analysis of the intersection of state and federal workplace breastfeeding legislation. Cheryl is a contributing author to the Healthy People 2020 Law and Health Policy Project and serves as editor-in-chief of the USBC's weekly e-newsletter, Staying Abreast, Weekly Wire. She holds a bachelor's degree in English from the University of Illinois at Chicago and completed an undergraduate fellowship at the Newberry Library. Welcome, Cheryl. And finally, Layla Barasa. Layla is an assistant professor in community environment and policy at the Mel and Enid Zuckerman College of Public Health, University of Arizona, and a consultant for the Western region of the Network for Public Health Law. Her research interests include studying the impact of laws and regulations on population health, both nationally and globally. Professor Barasa instructs a public health law course for public health and law students, and she has also provided numerous presentations at national and local conferences on a variety of critical public health law issues. Layla is an assistant professor in community, environment, and policy at the Mel and Enid Zuckerman College of Public Health, University of Arizona, and a consultant for the Western region of the Network for Public Health Law. Her research interests include studying the impact of laws and regulations on population health, both nationally and globally. And with that, I will pass it along to Angela.
Thanks so much. I think my slides will come in a minute, but first I just want to thank you, SBC, so much for hosting this webinar. It's a pleasure to be with you all this afternoon. I'll start by telling you a little bit about, I can see if my slides will advance. There we go. The background, I'll tell you a little bit about Healthy People, the overall initiative, the Law and Health Policy Project, as well as the role of law and policy in increasing rates and duration of breastfeeding. So what is Healthy People? Healthy People is an initiative spanning over 4 decades, which seeks to improve the health of all Americans using science-based national objectives with 10-year targets. Healthy People's overarching goals have evolved over time to reflect the need to not only eliminate health disparities, but also to achieve health equity, and in addition to promote quality of life across all of the life stages. Healthy People 2020, the current iteration of our initiative, includes more than 1,200 objectives in 42 topic areas, and also includes other elements like the leading health indicators, which are a smaller set of Healthy People 2020 objectives, selected to communicate high priority health issues and actions that can be taken to address them. The release of Healthy People 2030, this decade's initiative, was delayed due to the COVID-19 pandemic, but it's scheduled to be released later this summer, and I'll tell you a little bit about that at the end if we have time. So why did we think it was important to focus on law? Law in general is a tool that can be used as a lever to both protect and promote health. We thought it was important as we were thinking about Healthy People's overall goals and objectives to think about law, which can help to establish minimum standards for desired change. It also is possible to grant authority and flexibility to governments, especially at the state and local level, to respond to community needs. And we found that the use and application of law also has been demonstrated to both protect and promote health. What you'll see here is a continuum, and so when we talk about law, we're also not just talking about developing laws or creating legislation, but also focusing on the enactment, the implementation, the enforcement, and even the evaluation of laws. It's important to find out, are they doing what they're supposed to do? Do they need to be tweaked? And so this is a process that hopefully continues with laws and policies throughout to make sure they're having desired consequences and often are not also having unintended consequences that maybe weren't considered when the laws started. Oh, the slides are moving a little here, sorry. So I'll tell you a little about the Law and Health Policy Project is the group that helped to create this report. It's a collaboration, as you heard before, between the HHS Office of Disease Prevention and Health Promotion, where I sit and where Healthy People is based, CDC Foundation, who's our project officer, CDC, and the Robert Wood Johnson Foundation, who provided support. The project overall creates reports which are based on Healthy People objectives, talks about community bright spots, and we'll make sure you hear about one of those today. We're doing a webinar series, which is focused on specific Healthy People 2020 topics. And really an important thing for all of this is to share community examples of how laws and policies are being used in the field, specifically tying it to our objectives and data, but showing how they improve health outcomes. And then also as Healthy People 2030 is being developed, we've also been focusing on how law and policy can be better integrated into the next decade. You can see here our website page also if you're interested in seeing these materials as well as the report that we're talking about today. So when we talk about law and policy, we're thinking about it broadly. We're thinking about law and policy at different levels. So we're thinking about it at the federal, tribal, local, and state level, and even private sector. We're thinking about it in terms of the 3 focus areas for government, so the executive, the judicial, and the legislative branch. And we're thinking about broadly, not just legislation, but regulations, statutes, and ordinances, what the courts do, case law, things like licensure, which I know is important to many in the field, things like accreditation. So it's really a big picture view of law and policy. And that's something important to keep in mind as we tell you a little bit more about our report. Sorry, these are sliding a little fast for me. So when we talk about law and policy tools for public health, This is a framework which was developed by Larry Gostin. I'm sorry, somehow my slides are advancing a little here. I got it. Okay. These are legal and policy tools. This is a framework adapted from the Gostin and Wiley textbook, Public Health Law, but it outlines a set of legal and policy tools that can be used to alter the physical, socioeconomic, and information environments in ways that can both improve and impede public health goals. You'll hear more about specific examples of these today from our other presenters. But first, you can see there's direct regulation. There's the reverse, which is actually deregulation if the regulations that are causing issues or too cumbersome. There's something that we usually talk about together, which are taxation and spending, which are important tools, I think, especially for government. And then there's the court system. So thinking about redress through civil litigation, or those of us who are lawyers call it the tort system. One other point with this, which I know is something dear to USDC's heart, is that we also see law and legal policy as critical determinants of health. We had a federal advisory committee who helped us think about developing Healthy People 2030. And they wanted to point out that laws shape everyday life circumstances, societal institutions, and systems, and therefore actually can be influences on health and well-being in many ways. And we see this often has equity and social determinants of health implications. So now I'll tell you a little bit about the report development process and how we ended up with this report on breastfeeding. So we started working with our federal partners and with our work group and our project partners, thinking about which reports that we wanted to develop. And so we came up with criteria for what reports and what topics to focus on. We wanted to make sure it was a public health field, thought it was an area of priority, as well as our individual agencies at HHS. We wanted to make sure that it was an area where there were clear ways law and policy can improve health, that there was evidence-based knowledge that we could share, that there was data available. And at Healthy People, we work very closely with CDC's National Center for Health Statistics to make sure that we have the best data possible at Healthy People. And so also looked for the objectives that we were talking about to make sure that there was regular data there that we could show a health impact. We wanted to have the ability to highlight state and local laws and practice. We wanted to make sure that with our series of reports that we had a range of topics which would engage various partners, that there were emerging or established topics and issues was something we wanted to think about, so maybe we had a range of those also. And then, of course, we thought about kind of political and feasibility considerations. Is it a topic of interest? Is it something that we thought would make a report that people would be interested in reading about? What you'll see here is that one of the topic areas of our 42 topic areas for Healthy People is maternal, infant, and child health. So we thought this might be a good topic to explore for a report. This topic area for Healthy People 2020 has 73 objectives. They're in broad areas, including morbidity and mortality, pregnancy health and behaviors, preconception and health, disability, and so it's a wide range of issues. We also have 2 leading health indicators or priority areas. And then we looked with CDC's NCHS to think about what data we had around these objectives. And after these discussions and kind of doing some research, we decided to focus on, as you can tell, breastfeeding. And here are the 4 main objectives that are the focus of this report. The first is Objective 21, which is increase the proportion of infants who are breastfed. 22, which is increase the proportion of employers that have worksite lactation support programs. 23, reduce the proportion of breastfed newborns who receive formula supplementation within the first 2 days of life. And then finally, 24, increase the proportion of live births that occur in facilities that provide recommended care for lactating mothers and their babies. This is in the report as well as on our website, but this will just show you that for Healthy People, we have for each objective baseline data, and so at the beginning of the decade, we looked to tell what point or as a nation were we at. We have one nationally representative point. We came up with a 2020 target, so an ambitious target of where we thought we could go in terms of reaching that goal over the decade. And then we also provide regular updates, and so you'll see here are the most recent updates that we have in Healthy People for each of these objectives. And so what you can tell is just that for all of these, we're making progress, but we have work to do. And so we thought it was something that law and policy would help us to make a difference and be able to advance. We were fortunate to pull together a great report development team. You've met the other authors quickly virtually, but you can see they have various backgrounds, they have different expertise. We have law, we have medicine, we have focusing specifically on breastfeeding. So we wanted people with content expertise who come at this from different perspectives. We have a team here at ODPHP who also helps to work on this. And then we also have a working group, which is made up of about 12 people who also come from different areas. Some are federal partners, so work at places like CDC, as well as groups like the National Women's Law Center or USBC, or Blue Cross Blue Shield, who are really valuable in helping us to think about what's going on in the field and provided input and content to these reports. What you'll see, we have, each report has kind of a common structure. It has an introduction, background, and each report really dives into 3 or 5 interventions or themes. We know we can't talk about everything in the field, but wanted to make sure that we had a chance to hone in on a couple of examples where we could talk about how law and policy could help us reach objectives. We wanted to make sure to talk about what's happening in the field. And so we have these bright spots or community examples of places where people are using law and policies and seeing through evaluation, changes in health outcomes. And then we are sharing information like what legal research is out there, what are emerging trends and issues, are there areas for additional research, and then just kind of final opportunities for how law and policy could be helpful in reaching our national breastfeeding goals. As you'll hear today, the focus of this report really talked about 3 different main areas. The first is healthcare systems, providers, and payers. The second is employment and school settings. And the third is providing legal protections and accommodations for breastfeeding, including in public places. And this is, if you go to our website, you can see where the report is. The report's there, there's a summary. We have some graphics that we're really excited about that we hope you'll use and share. And so just to show you, if you go to our page, it's all kind of there. There are different sections and other topics if you're interested in seeing those. And I know my time is running out, but just to tell you quickly, we're developing Healthy People 2030. We expected to launch it in late March, but with the way things were going, held off a bit. And so work with a number of partners to get that, including really important public state input. We've been working on this for a number of years, but what you'll see for the next decade is that there was really an effort to keep the broad vision of health and healthy people, to make sure that equity and social determinants of health and now well-being are really at the forefront. But then also we were asked to think about how to reduce the number of objectives by at least half. And so we have 1,200 objectives in healthy people, but only about 900 or so that were measurable. And so we're aiming for around 400 objectives in this case to give that broad spectrum of what's important for health, but really to come up with a little bit more of a focused set of actionable priorities that everybody could work on as a nation. And we have a couple new categories, which you'll hear more about over the decade. But we really hope that by having less objectives, those with really great data and that are national priorities, that we'll be able to work together as a nation and make some great progress over the next decade. I have a timeline here, I think, which you all are welcome to look at, and my contact info. And with that, I will turn it over to Allison to tell you about the findings in the report. Thanks.
Allison, we can't hear you, so you might be muted.
No? Is that better?
Oh, there you are.
Sorry about that. The first key piece is that maternity care is critically important to breastfeeding outcomes. And so hospitals need to know that they can adopt evidence-based practices that support breastfeeding families. We'll talk about those in a minute. And that states and policies can encourage or require these practices through recognition programs or mandates. It's really important to recognize that there is compelling evidence that hospital policies matter. These are data from the PROBIT study, which was a randomized controlled trial enrolling about 30,000 mother-baby dyads in the Belarus, in the Republic of Belarus in the 1990s. And they randomized whole hospitals to either implementing the 10 steps or to usual care. And what they found was that all the way at a year after delivery, there were different outcomes in those babies that delivered in baby-friendly settings versus those who delivered without those steps in place. And so if anybody tells you, oh, it doesn't matter what we do in the hospital, they're going to do what they're going to do, show them this graph and say, actually, a year later, it matters whether or not moms and babies get appropriate evidence-based care in the hospital. Here in the United States, we found similar findings. I see with this mouse is a little bit jumpy. Here in the United States, we have similarly found that the number of evidence-based steps that moms experience are directly related to their likelihood of being successful. So these are data from the mid-2000s in the US and the infant feeding practices study. And the authors looked at the number of baby-friendly hospital practices that moms experienced and the likelihood that they had quit breastfeeding by 6 weeks when they wanted to breastfeed for at least 2 months. And what you see is that in the hospitals where moms experienced 6 out of 6 of the steps they could self-report, only 3% of moms had weaned by 6 weeks when they wanted to breastfeed for at least 2 months. But when moms experienced none of those steps, 30% of them had stopped breastfeeding by 6 weeks. So what this means is when we don't deliver this evidence-based care, we are undermining and derailing moms who really want to breastfeed. So this is really, really important to helping moms meet their personal breastfeeding goals. Now, how do we get these practices implemented? Well, I'm going to talk about 4 strategies. These include designation, reporting, technical assistance, and mandates. So designation in the US is administered by Baby Friendly USA, which is an organization charged with accrediting hospitals for implementing the 10 steps. And so we've made tremendous progress in the last decade. This map shows the proportion of live births in each state occurring in baby-friendly designated facilities. And we were at, I think it was 7% in 2010. And so as you see here, there are a number of states where more than a third of hospitals, or rather more than a third of births occur in BFHI designated facilities. So we've made a tremendous amount of headway. We also know that state level reporting programs can be helpful. So this was a survey we conducted as part of this project back in 2017 and looked at which states had active 10 steps designation programs in place. So these programs, basically hospitals report the extent to which they've implemented the 10 steps practices, and then they can be designated with stars or various other kinds of designations to show the extent to which they've made progress toward this goal. A key piece of reporting has been the MPINC survey. So MPINC was administered by the CDC and asked hospitals to self-report their maternity care practices. And this really became a benchmark measure of how well each hospital was doing in implementing evidence-based breastfeeding practices. And you can see that there's considerable variation around the country. In the West and the Northeast, there are a lot of states in the blue. In the Southeast in particular, and in the Midwest, folks aren't doing so well. But what has happened is that this report comes to maternity hospitals each year, and they can see how they're doing compared to the other states, the other hospitals in their area, as well as similarly sized hospitals nationally. MPINC underwent some revisions, and so the most recent data is from 2015, and a new version is going to be reported shortly. There also are data, jumpy mouse, on looking at the proportion of infants who are supplemented before 2 days of life. And so we know that some babies will require additional support for nutrition in the first couple of days of life, but most babies can be exclusively breastfed. And it was California that first looked at tremendous variation between hospitals within their state at the proportion of kids who ended up being supplemented with formula. And what you see here is that back in 2003, with a peak in 2007, fully a quarter of breastfed infants were getting formula before 2 days of life. And you can see that with efforts to implement the 10 steps and practice stewardship around formula supplementation, we're now hovering at about 17%, which is a big improvement. And again, this reporting allows us to monitor how we're doing and look at opportunities for improvement. It's also really important to provide technical assistance to help folks make these transitions. And the CDC invested tremendously in the transition to the 10 steps care through Best Fed Beginnings and through Empower Breastfeeding. And these were programs that sent technical assistance experts into hospitals to provide coaching, to provide quality improvement work, and to really help them make that transition from their current state to implementation of the 10 steps. And I think we cannot underestimate the importance of technical assistance. Folks don't go to a website and say, wow, these are 10 things we should probably do. Let's do it tomorrow, just because someone tells them it's a good idea. It's a huge process to change the way that we practice. And so these technical assistance programs have provided that coaching and support so that even when hospitals say, yeah, this is good, we should probably do this, thinking that and actually doing it are two very different things. And this technical assistance can make a tremendous difference. And then there are mandates. So in California, all perinatal units are required to adopt the 10 steps by January 1, 2025. That is written into state law. And that is a very effective way to get a hospital to do something, is to legally mandate it. In Mississippi, Blue Cross Blue Shield made baby-friendly designation a requirement for hospitals to receive Blue distinction for maternity care. And that has been a tremendous driver of quality improvement and practice change in Mississippi, which is a place that historically has had quite low breastfeeding rates and really huge inequities in breastfeeding. And we'll talk in a minute about how implementation of the 10 steps can be a really important driver of improving health equity. So breastfeeding starts in the hospital, but it certainly continues much longer thereafter. And so it's also really important to think about outpatient support. And so in putting together this report, there's great evidence from this study that was conducted in Scandinavia looking at a baby-friendly community health service. And so we think about the 10 steps for hospitals. These were 7 steps for breastfeeding-friendly community health services. And these were implemented in a clinical trial. And what the researchers found is that breastfeeding rates for any breastfeeding, for exclusive breastfeeding at 5 months and for exclusive breastfeeding at 6 months, were considerably higher in those practices that implemented these interventions compared with usual care. So these are similar but not identical to a number of different clinical breastfeeding programs. So North Carolina Breastfeeding Coalition has a breastfeeding friendly clinic designation. In California, the Breastfeeding Association has 9 steps to breastfeeding friendly community practices. There is a gold recognition for Breastfeeding Friendly Washington, and then health disparities toolkit that's been developed. So local coalitions and medical societies can really move advance the process by laying out these best practices and helping clinics to implement the things that we know are going to be effective to help moms and babies meet their goals. Moms also need access to lactation supplies and support. So a really important driver of this was the inclusion of comprehensive lactation support services in the Affordable Care Act and in the Women's Preventative Services Initiative recommendations. And WPSI, which is a consortium led by ACOG, looks at what health services are considered essential so that they can be covered by insurance. And these include, as you see here, counseling, education, and breastfeeding equipment and supplies before, during, and after birth. So it's important to recognize the parameters here. So this includes the antenatal, perinatal, and postpartum periods. So this requires coverage for support before delivery. So breastfeeding education programs during antenatal care, for example. They include lactation consultants, counselors, certified midwives, certified nurse midwives, certified professional midwives, nurses, advanced practice providers, and patients, and physicians rather. And then they're quite broad. They say those things which are agreed upon by the woman and her lactation care provider, including but not limited to double electric breast pumps and breast milk storage supplies. So there have been some evolution in terms of exactly what is required and how that is designated from the original Institute of Medicine report, which was used to inform implementation of the Affordable Care Act, U.S. Preventative Task Force in 2016, and the WPSI. And those are detailed here and included in the report for reference. This mouse situation is very stressful, I got to tell you. Okay, so one of the challenges has been that while the Affordable Care Act applies to private insurance plans that are not grandfathered, it does not apply to Medicaid. So this was a Kaiser Family Foundation report conducted in 2017 that looked at the number of states that cover electric breast pumps, manual breast pumps, breastfeeding education, and both hospital-based and outpatient lactation clinic support. So for mamas to be able to achieve their infant feeding goals, they really need all of these things. Hospital-based lactation support is wonderful, but if you can't get any outpatient support, a lot of the time you spend breastfeeding is outside the hospital, and so that becomes a real barrier to access. And similarly, for the very large proportion of women who return to the workplace, an electric breast pump is really important. If you're going to make milk for a baby and you're going to be working outside the home, you need access to a pump. So even for those folks who have insurance, insurance companies have not always been forthcoming with actually providing women with the benefits to which they are entitled. So this is from a toolkit that looks at the specific provisions of insurance coverage and then provides women with a model letter to send to their care provider. So this is from the National Women's Law Center, and women can download this letter and they can fill in the blanks and send this letter to their insurer and say, I'm supposed to be getting this, why aren't you giving it to me? It's really unfortunate that folks have to do this, and I think that it's been a little bit difficult to tease out exactly how often women have run into these barriers, but one of the ways we can really help is to streamline this process, because one would hope that if one is looking for cardiology care for chest pain, nobody's going to say, no, we don't cover that, you need to get a letter from your insurer. And we have to recognize that lactation care is fundamentally important to the health of moms and babies. This is from the same 2017 USBC survey that looked at states reporting their options for Medicaid coverage. This is a little bit newer than the Kaiser data, but you can see that not everybody responded to our survey. And you can see that a paucity of states had coverage for both pumps and lactation consultants through Medicaid. So one of the other important pieces around implementation relates to licensure and coverage of services. So not all states have a licensure process for lactation providers, and this back from CMS makes clear that lactation counseling must be covered without cost sharing when it is performed by any provider acting within the scope of his or her license or certification as applicable under state law. So that's a really important piece for understanding how to get lactation coverage enacted. So I just wanted to touch briefly on opportunities for improved care and coverage to support equity, because one of the challenges we have is that there are rather substantial inequities in breastfeeding initiation and continuation rates by race and ethnicity. And we know that these are the outcome of structural racism and long-standing issues that we're not going to necessarily fix with lactation, but we can attempt to mitigate those structural issues and improve outcomes. So this was a study that looked at implementation of 10 steps care as a function of the maternity facility zip code and the proportion of Black residents. And what you see is that several of these key practices are less common in areas where greater than 12.2% of the maternity facility zip codes residents are Black. And so this suggests that there are reduced opportunities for support in those communities that have the highest risk. Due to the legacy of structural racism and redlining and other policies that have led to residential segregation. So it becomes particularly important to make sure that we are not just implementing the 10 steps in hospitals that serve the more privileged folks. The good news is that baby-friendly hospital initiative seems to be more important for those in this study with less years of maternal education. So what this study did was to look at exclusive breastfeeding rates pre and post implementation of baby-friendly hospital initiative for women with less than 12 years of education versus greater than 13. And what they found was for women with greater than 13 years of education, baby-friendly didn't change much. But for women with less than 12 years, there was a 4.5% higher rate of exclusive breastfeeding at 4 weeks. And I think there are a lot of reasons this might be so. One of them is I think we tend to bring our biases to the bedside. And if we think that this mom, oh, those people don't breastfeed, which if you're thinking that, you've already made a major error and you need to take a deep breath and start over. But if that's operating in somebody's mind, so I don't need to worry about supplementing, giving this baby a pacifier, putting this baby skin to skin, because anyway, if we're putting everybody skin to skin, then we don't have that opportunity to allow our implicit biases to change care. I think we also have to look at the role of access to IBCLC services. And so this is a graph that looks at by state, at the number of IBCLCs per 1,000 live births and the proportion of live births that are Black. And what you see is this inverse correlation that in states with a larger proportion of live births that are Black, there are fewer IBCLCs. And so when you see that pattern, you worry about access to services and how we might mitigate those inequities. And this was something that was addressed in the CSI Removing Barriers to Breastfeeding report, where they note that there are not enough IBCLCs, particularly in states with high populations of people of color, and not enough who share the background of women of color. Fulfilling the educational criteria for IBCLC candidacy is easier for those already in the health profession, particularly registered nurses, and those able to afford the rather costly application fee, and both subpopulations that skew white. I'm really proud to be part of the Carolina Global Breastfeeding Institute, which has been funded by the Kellogg Foundation for RISE, which is a project to develop IBCLC training programs at HBCUs. And I think we can be strategic about addressing this issue, but when we see inequity, it's a function of a lot of structural factors, and we have to be deliberate about undoing those inequities in order to address them. So in terms of the pieces I wanted to talk about, in randomized controlled trials, hospitals and clinical level interventions improve population level breastfeeding outcomes. There are laws mandating private coverage for breastfeeding services, but Medicaid policies vary considerably, and that's an area where we need to make progress. And lastly, we need to recognize that maternity care and training among underrepresented minorities are top priorities if we're going to advance equity in this area. And with that, I'm going to turn this over to Cheryl. Thanks so much.
Thank you so much, Angie and Allison. My name is Cheryl Lebedevich, and I serve as the Senior Workplace Program Manager and Policy Analyst here at the USBC. So, I mean, obviously, we all know that anything that impacts the lived experience and the lives of women of childbearing age has an impact on breastfeeding. So, this was a big undertaking for this report. With lots and lots of areas. So moving out of the health care sphere, next we're going to build on what Angie and Allison have shared by exploring how law and policy is helping to leverage support for breastfeeding employees and students. We know that breastfeeding parents are separated from their babies for many reasons. In the United States, 61% of children under age 5 are in some type of regular childcare arrangement. And for the majority of families, this is due to a caregiver returning to work or school. The fact is that employment's the norm for women of childbearing age. 62% of women return to work before their child's first birthday, with 23% returning within just 2 weeks of giving birth. And we know that some groups are disproportionately affected. For example, African American women return to work on average 2 weeks earlier than women from other racial and ethnic groups. A lesser known statistic, I think, is the fact that 26% of undergraduate students are parents of dependent children, and that half of these students have children who are 5 years old or younger. And these circumstances have a significant impact on the breastfeeding experience. No matter where they are or what they're doing, breastfeeding mothers must pump breast milk about as often as a baby usually eats in order to maintain their milk supply, ensure that there is enough milk to meet the baby's nutritional needs while they're separated, and of course, avoiding discomfort, leaking, inflammation, and infection. But separation of a mother and child does not need to equal breastfeeding cessation. Research shows that policy interventions can make continued breastfeeding possible. Policies like paid family leave, laws that require workplace accommodations like break time and a clean private space to pump, and regulations that support breastfeeding-friendly childcare environments can all make the difference. The Law and Health Policy Report describes the policy interventions that have been shown to increase breastfeeding rates, with just some of the highlights featured here. We know that rates of breastfeeding initiation and duration are higher among women who have longer maternity leave, who work part-time rather than full-time, and have breastfeeding support programs in the workplace. We know that higher rates of breastfeeding initiation is observed in states with laws that allow break time for pumping breast milk, that require private areas to pump at work and include enforcement provisions. So meaning that there are consequences for employers that do not comply with these accommodation requirements. In fact, researchers have observed that states with enforcement provisions in pumping at work laws also have higher rates of exclusive breastfeeding rates as far as 6 months out. And research shows that women with both adequate break time and private space to pump are 2.3 times as likely to be breastfeeding exclusively at 6 months. And importantly, in California, the median duration of breastfeeding doubled among mothers who utilize the state paid leave program. And we also know that breastfeeding at 6 months is associated with support from childcare providers. So this could include things like feeding express breast milk to infants and allowing mothers to breastfeed on site before or after work. So we know that increasing breastfeeding rates improves health outcomes and reduces healthcare costs. And we know that paid family leave, workplace accommodations, and supportive childcare increases breastfeeding rates. There's been lots of evidence to show this. So that means that supporting breastfeeding workers is an important and effective strategy in our work to create a healthier nation. However, the spectrum of experiences is wide. It varies widely across the spectrum for families, and that's why breastfeeding is included as part of the Healthy People 2020 initiative. As you've heard during this presentation, Healthy People includes objectives on breastfeeding rates as well as on breastfeeding support measures like workplace support. One of the objectives that you can see circled here calls for an increase in the proportion of employers that have a worksite lactation support program. And the data source for this measure is an annual employee benefit survey from the Society for Human Resource Management. There are limitations to this data because it's not nationally representative, but it gives us a snapshot of likely trends across the nation. In 2009, the SHRM survey showed that 25% of employers reported providing an on-site lactation or mother's room. The target for 2020 this year was to increase this number from 25% to 38%. And so we are very thrilled to share that the most recent data from 2017 showed that we had actually surpassed this target, with 42% of companies reporting having a lactation room. So the work of individuals and organizations across the country, so many of you who are here today, I know are working tirelessly to support breastfeeding employees and students, and that work is paying off. But we also have a lot of reason to believe that we can do even better. And if we dive closer into the data, though, we uncover some pretty harrowing statistics about the breastfeeding barriers that families face. The US is one of only 3 countries in the world that does not provide paid family leave. The impact of not having a national paid family leave program is clear. Right now, only 15% of employees have access to paid leave. And for the lowest paid workers, those who are paid $10 or less per hour, this is actually an abysmal 4% of workers have paid family leave, especially when you compare that to 26% for the highest paid workers in our nation. Once breastfeeding parents return to work, there are new barriers. Research shows that only 40% of employed women have access to both break time and private space to pump breast milk during the workday, which is no surprise since over 9 million women of childbearing age are not covered by the federal break time for nursing mothers law, which we'll dive into a little more deeply soon. We also know that low-income women are more likely to return to work earlier and have jobs that make it difficult to continue breastfeeding. And since women of color are disproportionately represented in low-income, non-managerial positions, we know that they're facing the most daunting barriers to breastfeeding success. In workplaces all across the nation, women continue to face inflexibility in their work hours and locations. They report a lack of privacy. They report that they're forced to pump in unsanitary bathrooms. They routinely share about the challenges of safely storing their expressed milk and fears over job insecurity simply because they've requested or utilized workplace accommodations. And while these barriers to breastfeeding are very real and they have a significant impact on families, but in order to make it better, we first need to assess where we are right now. And so you'll be able to see in much more detail diving in the report itself, and I'm just going to go over some of the highlights here. So first, looking at paid family leave legislation. We know that the Federal Family and Medical Leave Act provides 12 weeks of unpaid job-protected leave each year for the birth and care of the newborn child of an employee, as well as in the event of other family and medical needs. Unfortunately, however, approximately 40% of the workforce is not eligible for FMLA protections. A growing number of states have passed paid family and medical leave insurance laws that are helping to give a greater proportion of the population access to paid leave after childbirth. The first state paid leave law was enacted in 2002 in California, and since then, 8 additional states, including Connecticut, Hawaii, Massachusetts, New Jersey, New York, Oregon, Rhode Island, and Washington, as well as the District of Columbia, have passed paid leave legislation. These state programs vary significantly. So they have different lengths of leave, different funding mechanisms, different wage replacement rates, and eligibility requirements, all of which are described in detail in the report. And while these state programs have contributed to the growth in access to paid leave in recent years, the fact remains that the vast majority of new parents do not have access to paid family leave. Looking at federal legislation on breastfeeding workers. So like I said, employment is the norm among women of childbearing age, and many breastfeeding parents choose to continue breastfeeding after their return to work. So there are 2 main federal laws that impact these workers. The Break Time for Nursing Mothers provision of the Fair Labor Standards Act was passed in 2010 as part of the Affordable Care Act and requires break time and a private non-bathroom space for breastfeeding employees to pump breast milk during the workday. The law protects employees who are classified as non-exempt, which means that they are eligible for overtime pay in the event that they work more than 40 hours in a week, and it covers them for 1 year after the child's birth. A second, less widely known law that impacts breastfeeding workers is Title VII of the Civil Rights Act. The Pregnancy Discrimination Act, which was passed in 1978, amended Title VII of the Civil Rights Act of 1964 to prohibit sex discrimination on the basis of pregnancy, childbirth, and related medical conditions. For decades, most courts did not interpret this to include discrimination on the basis of lactation, but then a Fifth Circuit court ruling in 2013 held that firing a woman because she is lactating or expressing milk is unlawful sex discrimination under Title VII. So the Equal Employment Opportunity Commission, which enforces the law, later published enforcement guidance stating that lactation is a pregnancy-related medical condition, and that less favorable treatment of a lactating employee could raise an inference of unlawful discrimination. So this means that an employee must have the same freedom to address lactation-related needs that she and her coworkers would have to address other similarly limiting conditions. These are very, very brief overviews, and if you're looking for more detail about these particular laws, we can certainly point you to a lot of resources. And in addition, though, more than half of U.S. states, as well as D.C., Guam, Puerto Rico, and the U.S. Virgin Islands have laws that impact breastfeeding employees as well. So these state policies roughly fall into one of 2 types of legislation. There's workplace accommodation laws. These are similar to like the break time provision, which typically require break time, a private space, or other accommodations for employees to pump during the workday. And then the second category are anti-discrimination laws. So these are like the Title VIIs, which prohibit discrimination based on sex, pregnancy, childbirth, and/or related medical conditions. Again, these state laws vary widely. So there's a range of coverage of accommodation requirements and enforcement mechanisms, and you can find additional detail about the variety of these laws in the report, and I encourage you to check that out. So while these state programs have contributed to increasing breastfeeding rates, you can tell that it's very difficult for employees and their employees to figure out which laws apply to them and how the law's requirements apply to their very specific workplace environment. Another important policy area is legislation protecting breastfeeding students. So Title IX of the Education Amendments of 1972 prohibits discrimination based on sex in education programs. And the Department of Education regulations specifically prohibit discrimination against a student based on pregnancy, childbirth, or her recovery. So this means that a student cannot be penalized for missing class time in order to pump, including if they have to step away to pump during a long final exam, and a professor must let a student make up work that they miss when pumping. The Department of Education also encourages, but does not require, schools to designate a private room for mothers to breastfeed, pump milk, or address other needs related to breastfeeding during the school day. So this is a great example of how legal and regulatory guidance come together to create the policy landscape. In addition, at least 4 states, California, Illinois, Nebraska, and Virginia, have laws that address the needs of breastfeeding students. And this is a policy area that has had a lot of increasing momentum in recent years. So I think we're going to continue to see a lot more. The next area that the report looks at is the policy landscape on breastfeeding and childcare. So although there are no national laws, federal policy and programs and initiatives address breastfeeding support in childcare settings, which therefore influences the experiences of breastfeeding families. For example, the Early Head Start program provides child development and family support services to low-income families who are pregnant or have young children. And the Early Head Start program performance standards require programs to safely store and handle breast milk and accommodate mothers who wish to breastfeed during program hours. The federal child and adult care food program serves more than 3.3 million children across the nation every year. And so their nutrition standards around breastfeeding have an influence on the experience of breastfeeding families, and by creating incentives for child care programs to provide a welcoming environment for breastfeeding parents. Another example lifted up in the report is the Let's Move Child Care Initiative. So this was launched in 2010 to address childhood obesity, and the initiative invited child care and early education providers to meet 5 goals, one of which was support for breastfeeding. So you've probably noticed the pattern by now that federal policies don't tell the entire story. Several states have laws that protect breastfeeding in childcare settings. Laws in Mississippi and Maryland require childcare facilities to accommodate breastfeeding, and a Louisiana law prohibits childcare facilities from discriminating against breastfed babies. In addition, every state regulates childcare in some manner. Many states have policies and regulations on accommodation requirements for breastfeeding families. So this might include things like training requirements on breastfeeding, milk storage, handling and preparation, protection from discrimination, accommodation requirements. So as you can see, again, the policy landscape surrounding breastfeeding employees and students is varied, it's complex, and there are lots and lots of angles to it. And unfortunately, there's still even more to consider, or fortunately. So with that, I'm gonna pass to Leela, who's gonna share about the policy landscape in community and public settings. Take it away, Leela.
Thank you, Cheryl. See if I can move these slides now. There we go. Perfect. I'm going to speak about providing legal protections and accommodations for breastfeeding and lactating mothers in public. Obviously, for breastfeeding mothers, they're not just going to stay home. We want obviously them to be able to live their full lives, and so legal protections for those mothers as they're out in public is the focus of this next section. Protections for breastfeeding mothers are primarily based in state law and can vary state to state. And I'll focus on a few provisions of state law. First, all 50 states, the District of Columbia, the Virgin Islands, and Puerto Rico have laws permitting women to breastfeed in public locations. When we started preparing for this report and researching, there was actually only 49 states, but in 2018, Idaho passed a law and became the 50th state in the US, so that all 50 states now permit women to breastfeed in public locations. 39 states plus DC, the Virgin Islands, and Puerto Rico actually exempt breastfeeding mothers from public indecency laws. And 19 states plus Puerto Rico exempt breastfeeding mothers from jury duty or permit the mothers to postpone service. Sometimes that might be that they can postpone it for a year or until they are no longer breastfeeding. Again, it depends on the state law, but there are provisions in state law allowing for postponement in some states. This is a map showing the public breastfeeding exemption from indecency laws across the United States. And another map showing the states that allow exemptions from jury duty or allow mothers to postpone jury duty service, again, either for sometimes for 1 year or for until they are no longer breastfeeding. So while many states have protections, legal protections in place, many states also actually lack provisions to enforce those laws. So as of 2016, only 10 states plus the District of Columbia and Puerto Rico permit breastfeeding mothers to bring legal actions against those who interfere with public breastfeeding rights. And enforcement provisions can include fines or claims against a company or organization. In a few states, Louisiana, New Hampshire, and Vermont, women can file claims with the state's Human Rights Commission if their rights to breastfeed have been violated. In New Jersey, a local health board can issue fines against an owner of a public accommodation that has violated the state's breastfeeding laws. And here shows some of the states that have enforcement provisions in place for violations of public breastfeeding rights. Again, obviously a majority of the states lack such enforcement provisions. And then air travel can pose another challenge for breastfeeding mothers because many airports lack facilities for women to pump milk or to breastfeed their children. So a 2014 survey of 100 airports found that only 8% actually provided a private lactation room. In the Friendly Airport for Mothers Act, which was incorporated into the FAA Reauthorization Act of 2018, it required all large and medium-sized airports to provide a clean, private, non-bathroom space in each terminal for the expression of breast milk. In some states, such as Illinois and California, airports are required to contain at least one lactation facility. Again, that might not be in a terminal that a mother might be in, so that might pose a challenge to get to that specific terminal with the lactation facility, but those airports are required to provide at least one lactation facility. And then the Bottles and Breastfeeding Equipment Screening Act, BABES, which was signed into law in late 2016, requires that TSA provide training to ensure its officers consistently enforce TSA special procedures related to breast milk, formula, and infant feeding equipment across all airport security checkpoints. And I think we've all heard stories from breastfeeding mothers that have faced challenges of getting through security at an airport. And so this law tried to alleviate those challenges by requiring this training. Go back, there we go. There's also protections in certain government buildings for breastfeeding mothers. Mothers may breastfeed at a federal building or on federal property as long as the woman and child are otherwise allowed to be present in that location. And then the Fairness for Breastfeeding Mothers Act of 2019, which passed in this last summer, requires that certain public buildings to include lactation areas. So that was a new federal law that these public buildings will include additional areas that may have existed before or not, but certain public buildings would now include these facilities for mothers. And correctional facilities also pose a challenge for breastfeeding mothers. Approximately 4% of women who enter prisons and jails are pregnant. So at least 11 states and the US Federal Bureau of Prisons operate nursery programs that allow infants and young children to remain with their mothers. The period of time ranges from 30 days to up to 6 years. And in New York, the state of New York, if a mother's breastfeeding at the time she is committed, a child under the age of 1 may accompany the mother to the facility. And lastly, I know I want us to get to questions, so I'm trying to get through these slides quickly, but I wanted to also highlight our bright spot example. As Angie mentioned, the report contains community examples or bright spot case studies that illustrate how communities use law and policy to meet goals and attempt to achieve healthy people targets. And one of our great bright spot examples is Boulder County Public Health. And we are actually very fortunate to have Linda Kubecki from Boulder County Public Health on the webinar with us. So she will be joining us for some Q&A, which I'm excited about. But Boulder County Public Health actually saw a need and discovered there were many reasons why families in their community were not able to meet their breastfeeding goals. And so what they did was attempt to help childcare and healthcare providers, employers, and people who manage public spaces to create their own breastfeeding friendly policies. And they do this by developing templates and providing technical assistance. And they also partnered with Colorado Health Institute, external website policy, and several other Colorado County Health Departments to share the models that they've developed that are designed to promote breastfeeding. Beginning the work at the county level, they've also leveraged local partners, and that collaboration has really been at the heart of their strategy. They've shown some amazing results through their collaborative efforts, including about 95% of infant child care providers in Boulder County have been designated breastfeeding friendly. And as many as 61 organizations in Boulder County have been designated as breastfeeding employers. They all have formal lactation policies. And over 80% of Boulder County employees in a 2017 survey use the county's family-friendly policies, who use the county's family-friendly policies said they reached or surpassed their breastfeeding goals, far higher than the national average of 33%. So amazing results that we wanted to highlight in this report. And I think we will now shift over to Q&A. We're excited to hear some of your amazing questions. Thank you very much.
Thanks so much, Leila. Yeah, we do have a few questions that have come in so far. Please continue to enter your questions into your panel on the right-hand side of your screen. Just a reminder, you may have to click that little orange arrow to make it pop out. Also wanted to note that unfortunately Allison Stubbe had to sign off a little bit early. She's a very busy woman, and so any questions that are really best suited for her, we're going to welcome you to please do go ahead and submit them, but we are going to be working with her to provide written answers a little bit later on, since we're not going to be able to discuss them here today. The first question we have is, are any of the presenters aware of places in which taxation of infant milk formula products is being implemented by state or local communities to generate funding for improvements in the lactation healthcare system? And that's actually not something that I am familiar with. I'm curious, Angie or Leila, do you have a response to that question?
No, this is Leila. I'm not aware of that either, but that's a great question.
This is Angie. I'm not either, but we could maybe do a little bit of research and get back to you if we hear of any examples.
Yeah, Amelia, you might be familiar. We could unmute you if you have any answer on this now. We have a comment that in response to Allison's presentation, that it's really important to have a law for each state around public reporting. We have a question here asking about going into a little more explanation around enforcement provisions for state level legislation. So I'm happy to take that question. On the federal level, there are those two different laws. So the Department of Labor Wage and Hour Division is responsible for enforcing the break time for nursing mothers provision, and the Equal Employment Opportunity Commission is a separate federal agency that's responsible for enforcing Title VII of the Civil Rights Act. And there's a similar situation with state level legislation. So depending on the laws, in some states, it is still the Department of Labor that is really the go-to enforcing agencies, but many other state laws might specify specific agencies that are responsible for enforcement of that law in their state. So for example, it's the California Department of Labor is responsible for enforcing their laws. Yeah, several states have, it's like the Department of Human Rights might be the enforcing agency. I'll also say that for some states, it's actually very confusing to identify who is in charge of enforcement. So I'm going to pop a link into the chat window. We had done a few years ago an analysis of the intersection of state and federal law, and that was actually a really important area of focus for us, was trying to help people identify who actually is the agency in charge of this. So if my employer doesn't comply, where can I turn? We have a question about insurer coverage and variations that in what insurers are allowing their clients to access, which lactation support. So we will pass that one on to Allison Stubbe to answer later on. Thank you so much. We have a question around, what do you think would be the most impactful federal legislation to be enacted next? And I think we aren't able to offer any personal opinions, but Angie, I wonder if you want to share some of what was identified through our emerging trends.
Sorry, yes, I definitely don't have personal opinions, but I think, you know, some of the ones people had talked about were areas like paid and family leave policies that help. I know there are also some just around kind of, in general, making sure that our food policies, like the dietary guidelines and others, are representative of thinking about birth to 24. I know our dietary guidelines for the first time will this time focus on babies to 24 months, and I think that's a policy that could have a fair amount of impact if people learn more about you know, the value of breastfeeding and such. Those are just two examples. There are more in the report, and I apologize, I don't have that part open right now, but hopefully I will let the others provide thoughts on what they think might be helpful.
Thank you so much. Okay, the next question we have here is, does Title VII apply to exempt employees too? So one of the exciting things about Title VII now being interpreted to include lactation is that it actually has much more wider coverage. So that law applies to employers that have 15 or more employees. It also has a little bit more clarity around the enforcement mechanism, a lot more clarity around the enforcement mechanisms. So broader coverage. We have a question for Allison around insurer requirements. So again, we will pass that to Allison and share it all with the group. Sorry, I'm poking through now. Interest in strategies from states whose Medicaid plans are providing pumps and lactation consultations. So that is included in part of our report is an assessment of Medicaid coverage. And I did put in the chat, and I can share it again, the results of a 2017 survey we did that USBC did of state breastfeeding coalitions, which might be helpful for that. There's a question here of any legislation that allows for lactation telehealth insurance coverage, which I think makes a lot of sense in the current landscape, but I'm actually not aware of any. Leela or Angie, do you know?
No, I'm not aware either, but I think there have been a lot of new telehealth provisions in various states in response to COVID-19 emergency declarations. So it definitely is possible. I apologize, I can't name one off right now, but I think that's definitely, Cheryl, I agree, definitely important in this time right now.
We have, a comment. It's fabulous to reach out and help women of color achieve the IBCLC credential. However, in many geographic areas, hospitals will only hire RNs IBCLCs. Is there anything in progress to address this? And we can certainly respond by writing. Oh, and Catherine Sullivan says that the North Carolina Medicaid policy was amended to allow for telehealth. Look at where we're crowdsourcing answers. I love that. Oh, and GR answered too that North Carolina does. I think those are all the questions that we have for right now. I know that we have a few announcements, brief announcements from USBC, but first we have as a panelist Linda Kopecki, who really helped us pull together the bright spot on Boulder County Public Health. So would love to for Linda, for you to be able to share a little bit about what's happening where you are.
Hi, this is Linda Kopecki. Thank you very much. Just quickly, a response to one of the questions earlier, what would be the most important federal policy? In my work and my working with organizations, employers, and childcare, and many parents, I think paid family leave, by far, that would be the most impactful policy that could be passed right now. Just giving families time to get breastfeeding established before they have to go back to work, because so many have to go back to work or school within 2 weeks or 1 month, and you cannot get breastfeeding established in that short period of time. But thank you. I think one takeaway that we have from our work in Boulder County and in Colorado is that you need to look at organizations and policies as comprehensively as possible. For example, the Friendly Airports for Mothers Act, that covers travelers, but I'm really worried about the employees at that airport. For example, Denver International Airport is the largest employer in the state of Colorado. There are a lot of people working there who are of childbearing age and giving birth and breastfeeding, and they don't have any place or very few places, or even the flight staff the flight employees may not have places to pump when the travelers may. Or you're looking at a child care center, great practices for the families that that child care center serves, but what about the child care employees? These are low income hourly employees, young, childbearing age. Do they have access to pumping, time and space for pumping, or even breastfeeding if their child is there? So looking at things very comprehensively in all aspects of the organization. Thanks.
Thanks so much, Linda. Yeah, one of the areas that the report does speak to is the specific challenges for, like, airline pilots and stewardesses. Okay, I just want to do one final scan to make sure that we've captured our questions. And it looks like most of these are especially relevant for Allison, so we'll be sure to make sure we send those out to everybody with some written responses. These are mostly about clinical care and licensure. Thank you so much for submitting your questions. If you have anything else that comes up for you, please reach out to us at office@usbreastfeeding.org, and I will pass it back to Miriam and Danae. Thank you so much.
Thank you, Cheryl, and thank you to the rest of our presenters, Angela, Allison, and Leila, for that awesome presentation. So we just have one quick announcement that we wanted to make. As part of our efforts to create a landscape of breastfeeding support, the USBC will be hosting virtual identity caucuses to allow individuals of the same identity to be in community with one another. While prejudice affects everyone, the ways in which we are affected and thus the work that we have to do to address prejudice and oppression is different. And so these identity caucuses allow us to meet separately to do our different work. These facilitated safe spaces can be used to share stories and strategies towards solidarity and liberation as we collectively work toward a world with thriving families and communities. As you can see here, identity groups will begin meeting next Tuesday. And these spaces are deeply personal. And so facilitators of these meetings will encourage participants to use webcams as a way to ensure a safe space for authentic dialogue. You can register for your group's caucus at the link that's been provided in the chat. All right, and that will bring us to the end of today's session. Thank you again to our presenters and to all of you for the vital roles you're playing in improving maternal, infant, and child health throughout the country. Please complete the webinar evaluation that should pop up at the end of this session and let us know how we're doing. Your suggestions are valued and also help us design future sessions that are most relevant to you. You'll also receive a certificate of attendance when you complete that evaluation. So please take care. Stay safe, and we look forward to having you all for our next webinar. Thank you so much.